Hi, good evening, everyone. Welcome to Nirvana's Public Health Forum. Nirvana is a platform which was founded last year in July. We just completed 1 year, 2 days ago. And the main purpose of this platform is to make information related to public health more accessible, more understandable. And Public Health Forum is one of such ways to bring the discussion around public health more accessible to more people. And we also aim to promote collaboration through this platform. So if there's anybody you're seeing that you would like to get in touch with, you can reach out to me or you can directly message them here. So thank you all once again for joining us today to discuss privatization of healthcare in India. My name is Parth and I'll be moderating the session today. We have 4 highly experienced speakers joining us today. I would like to start by giving a short introduction. We have Dr. Sunil Chandy. Sunil sir is the former director of CMC Vellore and is currently working as the Chief Medical Officer at ITC. As a student, I've always heard him talk about the importance of the preventive and social aspect of medicine. And I'm really glad that he's here today to discuss this very important issue. Thank you for joining, sir. We also have Dr. Sonali Vaid, who is a physician by training, and she has experience in global health, quality of care, and patient safety. She's also the founder of Include Labs, which is an organization that is working to improve quality of patient care by using improvement science. Thanks, Sonali, for joining us today. We have Dr. Raghuraj Hegde. He's an ophthalmic plastic surgeon practicing in Bangalore. He's one of the directors of the Vision Mission, a non-profit organization providing eye care solutions to underserved areas in Africa, South and Southeast Asia. Thank you, sir, for being a part of this session today. And finally, we have Professor Devi Vijay. Devi is a professor at the Indian Institute of Management, Calcutta, and her research explores precarity, institutions, and collective action with a focus on healthcare. She was also awarded the Fulbright Nehru Postdoctoral Fellowship in Public Health in the year 2016 to 18. Thank you, Devi, for being here. So today we are going to discuss a very important topic, which is privatization of healthcare in India. And we have noticed, I'm sure all of us have noticed, that Indian healthcare system is becoming more and more privatized. So the aim of today's forum discussion is to discuss the impact privatization has on the healthcare structure of India. And I would like to ask Sunil sir if he would like to start off by talking about nuances of privatized healthcare in India. Over to you, sir.
Let me just pull up. Okay, can you see my screen and hear me as well?
Yes, sir.
So good evening, Parth and all the other co-panelists. It's a delight to be on this very special forum. I guess I'm a little fish out of water here because I'm a hardcore tertiary specialist. So people might wonder, what is this cardiologist in a corporate organization talking about public health? But there is a story in this that as a specialist towards the later part of my career, it began to dawn on me that all that we do with high-tech stenting and very flashy things and very dramatic therapeutic options was really not reducing the number of people who were coming to our ICUs. So there was a problem in wanting to just be at the curative end without really us specialists having any kind of commitment to understand and assess what is really going on. There was a time when there was a flurry of young women, in the premenopausal age group who presented with myocardial infarction in Vellore. And it was a bit shocking because that did not fit in with the expected patterns. We never found out the reason it abated by itself, but it did open my eyes to the larger problem that we are dealing with. And I guess from that time, 5 years ago, it has become much bigger. My passion today is not practicing cardiology, but to actually go into many aspects of public health, although I'm not a public health person. but it's a joy for me to share what I have learned through my journey into these nuanced nature of private healthcare to which I belong. 50 years ago, this is not my picture, but 50 years ago when I was a kid, this was healthcare. There was a Bengali aged doctor, very friendly, who had a small room with a compounder. And he would give, I guess, the same pudiya and that bottle with graduation paper stickers. And it worked very well for anything from fever to diarrhea to constipation to injury. He had a solution for all. I'm not saying that that is the ideal form of healthcare, but I often wonder whether we are, after all these years of high tech and new understanding, better from that experience that we all had as children. So I'm going to quickly cover this in the next 10 minutes on the nuanced nature of private healthcare to just discuss it under the following headings. When and why, what was the purpose of privatization, and how did it come about, and how it's gone through this nearly 40-year journey. Who stewards it? Who stewarded it initially, and who stewards it now? And whither goest us? Where are we going in terms of what lies ahead from a national need-based perspective? I want to highlight that we are talking from a national calamity of health, and not from what may be state of the art. We're looking at it from what India needs at this point in time very urgently. Now, this is a picture that we need not spend time about. We know that there are two kinds of health systems, the public, which has primary, secondary, and tertiary care, and of course the private hospital system, which the majority today is for profit, and a small segment of to which me and Parth, and I'm sure most of you belong, is to the not-for-profit section, which has a different philosophy of health delivery completely. But what we all forget is that there is a larger canvas of public health, which is so important and not stressed enough in our medical school or even during our practice years. The social determinants of health, the financial aspects of health, the enlarging canopy of pollution that is impacting on various organ systems are all part of that public health hazard to which we pay very little attention. Time not permitting, I'll restrict myself to the for-profit because that is really the topic that we're brainstorming. So we all know that in India, at least, it was in the 80s when private healthcare made its entry in a very gentle way, and that was triggered by this slogan that we all learned as first-year medical students in community health, Health for All by 2000. Very ambitious slogan, and we're all asked to work for it without knowing what it meant. But that for many people who were innovative and very far-sighted to look at whether there can be an entry of a privatized system, because at that point in time, private healthcare occupied only 10% of the healthcare canvas. And it was in 1983, the National Health Policy, which defined the per capita expenditure on health for an average Indian to be 13 in the poorest of state, to understand that there was very poor government spending on health. And the private care already at that time, through the family practice systems or what frugal system existed at that time, people were actually spending 1.5 times of what they were spending in hospitals. That was a good beginning, and India witnessed an economic boom, raising the per capita expenditure from 13 to 320. That was an eye-opener for the private sector. We also learned that the total expenditure now was 6% of GDP. And of course, later on, it became in the 2000, resulted in the mushrooming of the entire canopy of private healthcare, bringing in imaging and the technology that was available. So it really boomed, and people got onto it because it was comfortable, and so kept track with the general affordability that Indians had over the last 10, 15 years or so. So this is how the health envelope grew from a meager 1980s to almost kind of enveloping majority private healthcare by the time we were into our new millennium. Who started? Why was it started? It was no doubt started with very good intentions to augment the impoverished state of public health care, to which the government could not contribute more because there was a downturn of economy in the early 90s, and then, of course, it picked up. It was also to experiment with this new paradigm of health where you pay. So you higher value, fee-for-service paradigm of care, which is more comfortable, very quick, and very accountable. It was a trial for the private sector to establish this new paradigm. Of course, it was also to raise the standards of Indian healthcare, which was not much to talk about, take home the sentiment, and of course, make India a global healthcare destination. And improve the skill of medical doctors and nurses who were very poorly paid in the public setup at that point in time. So all these intentions were good, and the way they did it, the how of this was achieved very smartly by the innovators of public health, the forefathers of public health in India, by understanding the gaps and filling those in terms of one infrastructure. Suddenly, there was a host of new infrastructure which was state of the art, moving it from an essentially clinical, like the picture I showed you, one stethoscope and one tongue depressor, to more laboratory-based approach in health, which made it more accurate, at the same time more expensive. Also, to have hub and spoke model, they were largely placed in urban landscape with the satellites in the periphery, not giving much attention to the rural or semi-urban locations. They did not believe in the Hippocratic constraint of no advertisement, ethical way of, they went big on publicity and marketing. Airports and bus stands had pictures and slogans of come here, we'll save you, to what you see right here on the screen, which says, what is that? It says, we fix the most broken hearts, very attractive to lure patients into their new platform of care. Of course, without saying so, it obviously catered to one section of society, which at that time in India was said to be percent. The paying class, who come and get their service very quickly and go. So it suited them well. Of course, it became a very attractive resourcing base for investors to put their money in, because the annual growth of this particular portfolio was definitely much better than that they expected. Who are the stakeholders? Initially, if you trace back in India, the forefathers of the privatized healthcare were NRI physicians who were returning home after spending a lifetime in the US, lots of money, and they wanted to come home and engage themselves. So it started with that. Not one, but more than one families did that. But they were all Indians who were returning the Garvapasi of medical people who were in the US for many long. They essentially were family businesses, which started with concerns about how they would establish the family and the new generation of family members into the healthcare business. And to a large extent in India, that still goes on. But then it became very attractive for overseas venture capitalists to say, hey, there's gold here. And they were willing to pump in a lot of money from over, unconnected with the Indian scenario, but willing to put a lot of money. As of this morning, there's a large group from Singapore that has bequeathed almost $10 billion into, or rupees, I'm not sure, a huge amount in one particular healthcare system. This is important for us to understand that now there are a whole host of stakeholders. It's not doctors or doctor-related people anymore, but almost everybody is a healthcare stakeholder. The construction man, the designer, the interior designer, the pharma, the tech giants, financiers, even aggregators like Swiggy and all that are getting into healthcare. I was very pleasantly surprised amused to see that the inventors of Spotify got into healthcare, the music people. So that's how the stakeholdership is changed. Definitely, the foray of private healthcare into India has transformed care in general. Definitely raised the bar of quality. And today, as of last year, they cater to 58% of inpatient, 80% of outpatients, and 40% of hospital beds in the country, which is by no means small. And definitely they are more quality oriented and offer comprehensive care because that's the way their accountability and safety standards are designed. It is very for the patient, and they take great pains to make sure the patient is happy. There is customer delight or patient satisfaction. It definitely has reduced to a significant extent the number of people who are seeking treatment outside, like many of our ministers. Even the Prime Minister and presidents have had bypass surgeries in India, which would not have happened 50, 60 years ago. So that's a feather in the cap of private healthcare. And it has done the reverse also by attracting native medical expertise. Many people who have returned back from the US to India looking at various aspects of family affiliation and better thing. And this is sourced from a good journal, which I have quoted below. It's also opened up career options of good significance for people who are not in teaching hospitals, but who would still like to practice good medicine. The private network offers a good platform for them. There is a flip side, and that is where it gets nuanced. Despite all that has happened in the last 35, 40 years, this is the sad truth that our pathology, the reservoir of pathology throughout the world, and specifically in India, has not dented one bit. It's become bigger. If you look at consolidated data on diabetes, on NCDs, it's got worse. And this is a point I started with, that tertiary care may not be the answer. Private care may not be the answer. Then we have, I think, do you have a control on that? I don't know, for some reason it's paused.
No, so I think if you can just click on the slide, it should change.
Okay, right.
Or you can just stop sharing and reshare, maybe that will work.
I lost my cursor also. I don't know. Okay, now what should I do?
I think we can stop the
Yeah.
participant sharing from our end once.
Yeah.
Yeah.
Okay. Okay, can you hear me now?
Yes, sir.
Yeah.
Okay. I don't have the video, but that's okay. I mean, I don't have the faces on the gallery, but that's okay as long as you can hear me. So I was saying that the disease pool has consolidated and become much bigger. If you carefully look at the Oxfam report and the global burden of disease, various other reports that are neutral, you'll find that this is the truth. And it's largely because of the conversion of a double disease burden into a triple burden, which means along with the communicable diseases segment and the enlarging NCD, to that we had to add in 2020-21 the viral epidemic, which seems to be an ongoing open-ended problem, although it is not to that degree of devastation. But every year there is a large pool of people who fall sick with viral diseases. The NCD has become bigger, and the viral reservoir is also becoming slightly bigger. And for a country like India to handle this full burden becomes a problem. Prohibitive cost of care, and I think to this we must admit that the private care structure has contributed significantly in a negative way. And we know from Government of India records that 3 to 65 million of people are pushed into poverty, below poverty line every year. And that's been consistently shown in the last 2-3 years. This is the paradox that as of this morning, what is on my left also shows an investor that is willing to pump in 10 billion into here for 3 years because they see a CAGR of 20% and $8.5 billion business and capturing the market in urban, semi-urban, all that. In that whole write-up, one word is not there, patient. And that's very sad, because that then will vouch for what is on your right side. The out-of-pocket cost for cancer patient is average 3.3 lakhs a year. And that's just cancer. If you look at all the NCDs that are causing the hospital beds to fill up, liver diseases, non-cirrhotic portal fibrosis, liver transplantation, so on and so forth, the costs are humongous. So much so that an average Indian will find it difficult. And this is validated even in Harvard, in their experience, which actually shows that this is a report on India, which actually shows that the country's rapidly developing health system, remains an area of concern, because health insurance programs are just not able to keep up where it matters. There is a big struggle, which unfortunately I think will only get enlarged. Private and public health systems are placing huge demands. And this is where we are failing badly in this, getting caught up in this whole cloud nine of AI, and there is no talk about skilling or getting manpower of good quality. We are all so caught up in this warp of technology and AI that is going to spell doom for real medical care in future. The privatized health system is nuanced by this ethic of low or no priority for the poor. There are anecdotal cases where there's no scope for charity. We've heard tragedies about how 7-year-old child in New Delhi died because of dengue. 4 private hospitals refused care because there was no money. The child died, and in the angst that followed, both the mother and the father committed suicide by jumping off from the 7th floor of a nearby building. This happened in 2015 or 16. Similar cases, unreported, do happen. So there is this Western approach of maximal care at any cost. You go to a hospital today, you're hardly examined, which they will just give you a whole battery of tests, which includes imaging of the costliest nature. Any suspicion of cancer, a PET is ordered. And then they work it retrospectively, this retromedicine, to see what you have. And finally, you may have a viral fever, nothing more than that. That's the truth of how it's placed. And extremely high overheads because they are very quick to adopt latest technology for what's called the first mover advantage. They want to be the first one to get a technology, a new machine, because that sells well and that adds to the brand value. I have removed the identity, but you can see that this is the nature of the business of health. Sadly, there is no mention in any of the leadings and how much of patient care is given. It's all about money. And this is because of the nuanced nature of how healthcare is placed.
And so what did your paper find? What happens when these companies public?
So we can't see your screen. If you could just reshare your screen.
For the government, so we do have these hospitals become modestly profitable. So potentially they may not need ongoing subsidies. We also find that they actually start serving fewer patients. And then specifically, there's a disproportionate reduction in the number of Medicaid patients served by these hospitals.
So this is true in India, although we don't have Medicaid as such. So to the final slide, where are we heading? It's not very good news in my perspective, and I think I'm fair because I'm by my DA coding a tertiary specialist, but I'm increasingly convinced that the way we are heading is not in the right direction unless we do a course correction. Because healthcare is increasingly becoming inaccessible for the larger masses. It has become increasingly unaffordable for the ordinary Indian. All the posts on internet say healthcare revolution, healthcare transformation. But honestly, I ask myself, have I seen any transformation? Not yet. With all the devices, with all the technology, it really has not made any dent. And God forbid, if we have a COVID-like illness today, we'll better off with public health in shambles. I'm not sure whether that question is answered. Public and primary healthcare are the game. Refuse to accept this. There's so much of focus on high-end medicine. And this question that troubles me, will technology be eventually be cost-effective? So these are the facts that there is no health transformation unless public health is addressed, and we must do that urgently. The triple burden pathology is in epidemic proportions in India. Technology is unavoidable. It's a good slave if we know how to harness this wild horse, including AI, but a very poor master, which it's tending to be the way it is being positioned as this revolutionary panacea for everything. And private care, I believe, all the private care put together with all its money and scope and manpower has the bandwidth to enlarge its social footprint. I believe that 10% of every private care ecosystem must be devoted and committed to public health and primary care. It will make a difference to our nation. And as always, I believe that healthcare is a service. It cannot be made an industry. But if you see a write-up, the connotation of healthcare is healthcare industry. The reference is industry. The semantics is industry, not a service. And that's very unfortunate, in my opinion. So I go back to this wish of mine that if we have a public healthcare system which forms the good platform for primary care, family doctor practice, and we make one doctor part of our family, it will reduce the total morbidity of disease and the burden it's placing on this high-tech, modern health system that we have. Thank you. Happy to take questions, if any.
Thank you, sir. You summarized really well, where it all started from and where we are headed. And like you mentioned, it started with a different intention, but now the divide has worsened, be it the economic or the accessibility. And I have a few questions for you, but I'll keep them for the end. I would let others also finish speaking, and then we can have an open discussion with our participants also being involved. I would ask Sonali next if you could shed some light on the quality of care, because what is assumed mostly always is that if I go to a private hospital, I'll get better quality of care. And that's why people don't really access public health centers, even if it's next door. So if you could share a bit about that, what are your views on that?
Thank you, Parth, and thank you, Dr. Chandy, for laying the groundwork for the rest of the session. So I have a question for our participants here. How many people think quality of care in the private sector is better? So you can just type yes in the chat. And while you're answering that, so the question is the quality of care in the private sector better than the public sector? So yes for private sector. And I'll come to that. The other big thing, which is really linked and which will affect quality of care in India, is the plan to do a public-private partnership for district hospitals. Some of you may be aware of this, some of you may not be aware. We'll share links to this later. So basically in January 2020, just before the pandemic, in the budget plan was announced that we need more healthcare workforce. So the idea was that public district hospitals will be given on a lease to private players, provided they set up an associated medical college. What this means is that the only secondary level facility in our districts and across the country, which is free at present, which has been built with taxpayer money, will be handed over to the private sector, right? So the question we are talking about is not about whether it's bad to have private sector or good to have private sector. We need the private sector, and Dr. Chandy very clearly described some of the advantages it has afforded us. And even in the beginning, when he showed the photo of the Bengali doctor, that's how healthcare has been. You know, you give 5 rupees, 2 rupees, 10 rupees, you have a private provider giving you care. So this is not an argument against the entirety of the private sector. It is a question of who is responsible for healthcare and what is that actor doing, and whether in a country where undernourishment is increasing, where stunting is at an all-time high, can we afford to make people pay exorbitant amounts to get care? That is the question, right? So it is definitely not about critiquing the entire existence of the private sector, right? So what is the responsibility of the state? Is it okay for public assets built with taxpayer monies to be transferred to the private sector? And I'm just posing a question here. And what is the state's responsibility here? So I'm just looking at the question here. Yeah, okay. And under this plan, what will happen at the district hospital, there will be some free beds and some market beds, right? So we can envision, we can hypothesize what might happen once this plan is in place. One, if I'm living in a village and so far I've gone to this free district hospital, and now I come to know there's some market beds, some free beds, maybe at one visit I'm asked for money, what will I start doing? I will bypass it and go to an already exhaustingly overburdened medical college, right? So we have completely circumvented the primary, secondary, tertiary pathway, which is already dysfunctional, but we are making it worse, right? And that's the health system we are looking at. Some states have already taken this up. Some states have flat out refused, such as Kerala, which is obvious. And the only justification that is being given for this plan, which is a very brief justification, is that India has a dire shortage of qualified doctors. It is practically not possible for the central or state governments to bridge the gaps in medical education with their limited resources and finances. And Kiran Kumbar, who is here, who's a researcher who's a physician and has studied the evolution of modern medicine in India, he wrote a very nice article in which he quotes, he goes over what India's leaders envisioned at the time of India's independence. And I'm quoting here, he said that at that point, India was a much poorer nation. We had famines going on. We were a newly independent country. And yet our founders embraced the idea that the state should assume full responsibility for safeguarding the health of the nation. How then is it that 75 years later, the government is saying it does not have the financial resources? What happened to our ambition? And that's a question for all of us, right? So we know that healthcare is already skewed towards private provision, but there is a small silver lining. I don't know what's the latest since 2020, but up to 2018, there was a slight reduction in the number of hospitalizations in the private sector versus the public sector, and the number of OPD visits. So there was a declining trend from, say, 2004 to 2018. I don't know what's the latest, right? So it's not a question of whether people want public care or not. People do want public care. That's what's shown by the trend. Is the state answering that demand, right? Okay. I'm just checking my notes here. So now coming back to quality, and I'm just going to see if anybody has. Yes, so Arjun says several social sector hospitals are top grade, etc. Priyanka says no. I can see we have a very selection bias in the audience here. Immunization programs are excellent. Budget should be increased. So to be honest, I think the evidence is weak. I think the area of quality of care is nascent in comparison to other things. We don't have enough work on quality of care. And it's only in the last 15 years that there has been substantial work on this area. Otherwise, the assumption was, give people access, everything will be fine. Institutional deliveries, everything is fine. But when you see programs which have increased institutional deliveries, they have not necessarily improved outcomes of care, right? One person to take note of who's done work on quality of care is Jishnu Das. So good starting point to read about work on evaluating quality of care. And some of his work and other people's work, what it shows that quality of care is questionable both in the public and in the private sector. Both need a lot of improvement. And incidents of harm, incidents of errors, poor quality care happen all the time. They're happening as we speak, right? But neither private nor public hospitals are required to disclose the outcomes of care, infection rates, anything, right? If I take my mother to a government hospital for knee surgery, I have no way of knowing what her outcomes will be. So even it's not just, I like to think of two Indias, one that goes to the private sector and one that goes to public sector. And here by the private sector, I mean the corporate, shiny private sector. It's not just the one that is going to the government sector out of necessity that is suffering. We all have faced challenges in providing care to our loved ones and to ourselves. We don't know what we are getting. There is information asymmetry, even as qualified professionals. And for a long time, I assumed that at least service quality is better in private hospitals compared to public hospitals. But then I came across this study in which they also evaluated service quality in private facilities, and not necessarily the corporate ones. This was I believe in Jharkhand, Maharashtra, and Uttar Pradesh, if I'm not incorrect. And one of the things they looked at in terms of service quality was the presence of a birth companion. So having a birth companion is now mandated by the government, it's in their guidelines, etc. But even in private facilities, there was poor adherence to having a birth companion during delivery. And I know from anecdotes shared by family members, friends who've delivered in private facilities, that they were separated from the baby, that breastfeeding did not start immediately. So even in that sense, we cannot assume that the quality is better or worse. Also, interestingly, in terms of provider qualifications and knowledge, very, very interesting work. We assume that modern medicine doctors will do better than alternative systems. But when they compared practices, the knowledge they're using standardized questionnaires or patients of Western medicine, modern medicine versus others in higher performing states versus lower performing states, the non-modern medicine doctors in higher performing states had better knowledge than MBBS doctors in states like Uttar Pradesh, right? So we really, really need to get more nuanced. I like the choice of word by Dr. Sunil. We assume we understand quality. We assume we know where we will get better quality, who is a better provider, but we may be very much off the mark, and we need more work in this area. And we have to recognize that this is not just a question of sort of clinical, technical interest. These are people's lives, their savings. And even despite having COVID, being through a pandemic, we have still not ramped up the health system. Just a month ago, there was somebody else searching for an ICU bed. Of course, this was somebody who could not afford the private sector, and they were not getting an ICU bed in the public sector. So a lot more needs to be done to strengthen both the public and the private sector in terms of quality of care. We need levers to nudge, cajole, help, engage the private sector in improving their quality of care. And at a larger scale, we need to really go back to the vision of our founders and start seeing how we can actually stop this accelerated momentum towards privatization and make sure that our public health systems can be better and deliver more respectful and dignified care for the people. And it is possible. I went to the AIIMS newly built OPD 2 weeks ago. Fabulous, it's an exception, but it is possible. And I'm sure there are many other wonderful examples in the South of how good care is being delivered in the public sector or the non-for-profit private sector. And we need to push further on this agenda. Thank you.
Thanks, Sonali. Again, it's really nice to hear you talk about quality of care. I heard you before as well. And I remember you shared a report last time, which was published in the Lancet, which showed that more people die because of poor quality of care rather than lack of access to care. And like you mentioned, there is hardly any standardized care in the country. Again, a lot of disparity. And the most important question that you ask is, who is responsible? And if we look at, the government has tried by bringing in Pradhan Mantri Jan Arogya Yojana, Ayushman Bharat scheme. But again, like we had a forum last time on that, Ayushman PMJ, it hasn't really addressed the inequity and the disparity. And unfortunately has actually worsened it. So I'll share a link to that forum as well, if anybody is interested. But thank you for stressing on those quality aspects. And if anybody is interested to get in touch with Sonali, I'm sure you can leave your link to your website below. She's been doing some amazing work in quality of care, mainly research, centered around research. If anybody is looking to collaborate with her, it will be a great opportunity. Moving on to Dr. Raghuraj, we spoke about economics and how privatization has made everything expensive. Who is responsible? Again, this is a very important question which has come up. So just going back to the impact of privatization, if you would like to talk a bit about the economic and the social impact the privatization has on healthcare in India. You're on mute, sir.
Yeah, just to 1 second. I'll share my screen. Are you able to see my screen?
Yeah. Yes, sir. If you could just make it full screen.
I think something's happening on this. Hi, yeah, I'm Raghuraj Hegde. I am actually from the private sector, and I work in a corporate hospital. I also visit a medical college, and I also work in a charitable hospital, which provides care. It's a private hospital, but it's a charitable hospital, so it provides care at a lower cost. I also am a part of a non-profit. It's called the Vision Mission. Called the Vision Mission. So it's basically we provide the capacity building, knowledge and skill transfer, and also some amount of funding when we have funding from other sources, from our donors. And sorry, okay, I just get back. Okay, I think you can continue the topic. Sorry about it. I just got my daughter. So so basically, I'll be basically speak about. Sorry. I'm so sorry. I shall I get back to you in about 2 minutes? You can continue with the thing.
Sure, we can go with Dr. Devi. If you could.
Yeah, sure.
Professor Devi, if you could just go ahead and.
Sure, I'll do that. Thank you.
So Professor Devi has been doing some interesting work in again, an access to care and the disparity in that. So she'll be sharing her views and maybe some findings from her study as well.
Sure.
Yeah.
Thank you so much, Parth. Again, it's been fantastic to listen to my co-panelists here. Dr. Chandy began with saying that he's a fish out of water. I'm not a clinician, but I have the privilege of being able to look into what clinicians do. And a lot of my work started with palliative care in Kerala. Parth and I have had a conversation on that. And, that was my take on my sort of glimpse into how public sector can be the starting point of some fantastic interventions, right? So a lot of what we studied started at the Government Medical College in Kozhikode, and then today, if you look at palliative care in Kerala, it's really the public sector and the community that is active, and so private is in many ways absent, and we can always have a conversation on why. But this is some of my more recent work, recent in the sense I've been dabbling with this since 2016, but sort of more actively through the last few years. And we're looking at closely at corporatizing healthcare. So I'm going to move right into it, building in many ways off what Sonali talked about in terms of privatization. I mean, Dr. Chandy laid the groundwork for it, so makes a lot easy for me. We know the sort of discussions both in academia and in media reports. I'm familiar with some of the people who are part of this forum and their writings, and we're broadly familiar with these conversations around the challenges that we face, right? I'm particularly interested in looking at the corporatization of healthcare, right? So when we're looking at corporatization, and so obviously as a subset of privatization, how do we understand what it means for care practices? So that's my specific interest, right? So just to ensure that we're all on the same page, corporatization, I mean, we're all familiar with corporate entities. So we understand the Apollo or the AMRI or the Max and Medanta and so on. So we have corporate entities. But what I'm also interested in is how corporate practices seep into other parts of the healthcare sector. So for example, in the public sector, and Sonali again alluded to it with the public-private partnerships, right? And then we have also non-profit organizations. How are we introducing elements of corporatization? For example, if you're getting funded by an impact investor, or if you're getting funded by a philanthropic organization, then what are you expected to show in terms of your returns on investment, right? So you see these corporate-like language that is that has seeped in many ways into the public and non-profit space. We of course have a corporate takeover of public infrastructure. So here is infrastructure that we've built over decades with public money, and then now it's corporatized. We also have corporate consolidation. So not just that there are diverse corporations in the country, but you have a few now emerging behemoths, right? So how do we respond to that? Because then it determines pricing, isn't it? So what is the kind of price that we're paying, and how elastic/inelastic is it? And then, of course, the question of institutional changes. And here I'm really talking about policy. So if you look at organizations like Niti Aayog and their documents, then you will find this flavor, the semantics that Dr. Chandy was referring to of corporate, right? So cost effectiveness, saving, and somewhere the patient seems to be missing in this conversation. So when I'm really looking at corporatization, this is a sort of canvas of how I'm looking at corporatization. And this is not a comprehensive sketch, but this gives you a flavor of what is it that we're looking at, right? Somebody referred to these new actors in this space. So we're familiar with hospitals, insurance, diagnostics, pharmaceuticals, medical devices. Some would even say telemedicine, think about medical tourism, these new actors, home healthcare solutions, and these corporate private solutions for this as entering the healthcare space. But we also have these strangers in the field, isn't it? Of elements, people whom we would not associate with healthcare prior to this, but we have consulting companies like McKinsey, Bain, PCG, with very robust healthcare practices, right? And then they lay out vision statements for public-private partnerships and consult with governments on how healthcare should look like in the country, Vision 2003 for Bombay, Vision 2020, 2030, and so on, right? So these are players in how we shape the field. Of course, the state is involved. We have venture capitalists, then we have private equity players like Temasek, KKR, TPG, and so on. And again, each of this can be a conversation in itself, right? How does consulting impact these actors? How does venture capitalists come into the scene, and so on? But for a minute, and for this kind of brief conversation that we're having, and just to open up the conversation, let's just look at private equity, right? And so some of these conversations around what private equity wants and does in this space. So private equity is really talking about, and this is a Business Today article, if I'm not mistaken, from June 2023. I have the reference somewhere in my slides. And this is talking about India's healthcare saw private equity firms investing around 2.5 billion in 2022. It was around 2.1 billion in 2021. The year saw KKR's exit from Max Healthcare with an exit value of 1.6 billion in 4 years. Another large exit was XYZ and so on. So you see, this is a really exciting conversation. You know, you have these big players, big money, robust, streamlined models coming into the picture. And I had the absolute delight of reading Victor Roy's recent book called Capitalizing a Cure, and I strongly recommend that to everybody, you know, who's interested in these questions. And he's looking at this whole process of financial services and what happens when they enter life sciences, right? So he's looking at the development of drugs for hepatitis C and what happens when these financial actors come into the picture. Now, just to borrow from him, and these are equally applicable to hospitals that are being now funded by private equity firms. The corporate strategy, now, Dr. Chandy began with that Bengali doctor who's sitting in his clinic, to now we have corporations with a particular strategy for how they're going to define care. And the strategy looks at market rate of returns, share prices, returns that are assessed every few months on a quarterly earnings call, what Roy refers to as quarterly capitalism. Investor exits, as we just see in this newspaper cutout on KKR. These are short-term returns, right? You want short-term returns and less about the long-term investing that healthcare requires, right? Healthcare, both goods and services in healthcare requires a more long-term orientation. And of course, the notion of future-orientedness, right? So speculative potential in this kind of investment. So we see that the language itself is of a different kind. Let's look a little more at this language, right? Why cancer? This is a Fortune 2023 article. Why cancer is the new cardiology for hospital chains. Rising incidence of cancer is basically good business, right? And so for public health people, I think it's challenging. Where do we begin? Right? Think this is an older article, Reuters 2013. Think like restaurants, healthcare, and so it finally becomes a question of metrics, right? That short-term investment. So should I invest in a restaurant chain or should I invest in a healthcare franchise? And that's really what you're looking at when you're looking at investments. So that's so we're looking at this new language of what is driving business in healthcare. Right. So, which is also in many ways shaping what we see as, complex work that tertiary health hospitals are serving. Look at this again. I'm blanked out the specific hospital's name, but the idea of a complete stroke care team and we're here for you kind of thing. Right. So, and just my last point on this particular point on question of private equity. So again, this is a pitch for how private equity is going to get into primary healthcare, and the family doctor concept. With more this. Their reading of it is that the family doctor is no longer relevant given the kind of lifestyle changes we're seeing. So we have to now shift from the trusted family doctor to the brand of a offering, right? So this is what good business wants. Now, and I'm going to give you as you can see, this is very skimming the surface of what is going on. But what we've been trying to do is map this corporatization and arguably financialization of healthcare into care practices at the micro level. So in the sense that what does it mean for doctors? What does it mean for patients, right? So and when we speak to doctors about some of these practices, I'm just giving you a snapshot of some of their responses. What we see is that, doctors are not seeing themselves, that they recognize that there are bigger players who work behind them. There's also a reason why we're focusing on doctors. We realize that nurses and other providers are equally precarious in this system, but doctors are also potential people who will run hospitals. So there is a reason why we are focusing on doctors, fully recognizing that there are other people who also get precaritized in this model. There's a lack of job security. Doctors say that they become less skeptical. You don't want to mingle in excess with patients. The relationship with patient changes because everything is being documented. There's a strong emphasis on documentation of what's going on. And interestingly, we find that there is a sort of difference between higher status or prestige doctors who come in with their own established practices and those who are sort of newer in the system or who may have made who are in a conflict-based situation in the workplace. And they find that then they are the ones who are more compelled to chase some of these targets that is now pretty much open information, isn't it? Targets around high-end technology, utilization of diagnostics and in-house pharmacies. The idea of patients as consumers, doctors saying that earlier, I mean, in a nursing clinic, I could just waive off the patient fees. But here, even if I waive it off, somebody else is going to anyway eat it up. And then the patients cannot understand this and they hate us. Right. So we keep talking about these, dyads between doctor-patient lack of trust. But what we sometimes miss, I believe, at least in this process, is these other actors who are obscured and who are in many ways pulling the strings. Right. So every time we're talking about doctor-patient trust issues, I feel that we should also be engaging with these, these obscured actors otherwise. Of course, with the patients, we know that there's a question of lack of trust, transactional relationship with care providers, patients traveling longer distances for care. We've just talked about indebtedness, hospital-related impoverishment. So I'm not getting into questions of quality, etc. I realize this is not black and white. There are shades of it. But our focus, if you realize, is just a tie between this corporatization and what does it mean. So what we've also been doing is to speak with patients and their experiences. So consider Mithu from Dhanbad, who's gone all the way to Bangalore, and she sold off her land. She's pawned her gold jewelry, and she believes that गरीब को भगवान रोग देता है, गरीब खर्चा करता है, गरीब रहते हैं, and ये भगवान की लीला है. So these are the articulations of indebtedness that people experience. And also, when we asked her what is it that she found which was good in Bangalore, although it was a private facility, she said the doctor touched my hand. He would refuse to touch my hand in Dhanbad, right? So, if that feeds into our conversations on quality, right? And then, of course, this is another interlocutor whom I work very closely with, who's had multiple surgeries in Calcutta. And then, she's very vocal that Kolkata mein to doctor ka business hai, and she's very, very militant about it. And this is not just Kolkata, but this is our site, right? And so on. So, this for me, I'm going to close without taking too much time and open it up for questions. But what we are trying to understand in terms of corporatization is questions of who is benefiting, for quality for whom, who is benefiting from this corporate consolidation, the gendered burden of care provision, which points back to our nurses and ASHA workers who are continuously thrown into this, even these private innovations that we keep doing. And then, again, what about conditions that are not profitable, which comes back to questions of palliative care, at least for me, from where I look at this site. And then so on. So we can keep, there are these multiple questions that need to be answered, but just to say that this is ongoing work for us, and I'd love to hear your feedback and inputs, and do participate in our study if you want, or write to us about our work. But thank you so much, and I'm going to stop there. Yeah.
Thanks a lot for that amazing talk. You like the last bit. I actually was like a nail in the coffin, where patient experiences. They always give a side of the problem which we usually don't get to know about in research papers or news articles. I would quickly ask Dr. Raghuraj to go ahead, and then we'll open the floor for discussion for everybody.
I'm audible?
Yes, sir.
Yeah, sorry for the disturbance earlier. So basically, I'm from, I work in a corporate hospital as well as a medical college, private medical college, but it is a teaching role as well as a visiting role. And I also am part of a non-profit, which basically is into capacity building in remote areas of South and East Asia. And also we have worked with some partners in Africa as well. So basically, what I want to talk about is basically what privatized healthcare has become in India. So medical education is becoming expensive. So this essentially means that we have a lot of MBBS graduates coming out every year. It's the government puts up 1 lakh MBBS graduates are there coming out every year. But after that, there are very few training positions post MBBS. So post MBBS, there is training positions are lower, and even after you finish your DM or your MCH, there are very few jobs for even for the specialists who are coming out of the system, and both in private as well as government. So it's not that we don't have disease, but we have a lot of patients to take care of. But there are not enough positions in our medical system, both in private as well as government, to take on this, and we don't have specialized. Of course, I take the point that not everything needs a specialist, but even if you're going to make 1 lakh MBBS doctors, you need to give them jobs. If they're not going to specialize, you need to give them jobs. So where is the jobs? That is the first thing. And Ayushman Bharat and other schemes are very well intentioned. It's actually earlier in my career, I used to actually have this in very high regard. But a taxpayer funded, a state funded private healthcare delivery is actually very unethical, because you're using you're basically using your taxpayer money to fund private healthcare, which disincentivizes building up private healthcare infrastructure. So it's a stopgap arrangement. It helps a certain amount of patients in the short term, but in the end, it's unsustainable, because at some point the money runs out, and the insurance companies don't pay out the amount that is owed to the hospitals, and the payouts are also quite low. So that makes it incentivizes the hospitals themselves to increase the number at the cost of patients. So you get substandard delivery at the end of it, which is not what we want for our patients. So the privatization of district hospital, the public-private partnership, Dr. Sonali already spoke about this, so I won't go much into it. So that again increases the cost of healthcare for even the village people, the rural people, even the smaller towns, because they're forced to go to a bigger center, a tertiary center, or epic center, which is already overburdened with patients. So the things that can be taken care of at the community health center or the PHC are coming all the way to the city to get it treated. So this increases the health burden of the Apex institutes. Also, it increases the cost for a patient to come all the way from a rural area to urban area. So all of this adds up to the out-of-pocket expenditure by the patient. So what is known as the medical poverty. So there is enough evidence to note that because despite having so many schemes, so many public hospitals, the out-of-pocket expenditure is very high. It's almost 80% of the healthcare expenditure is out-of-pocket. Last I checked, at least last when we had enough data to tell it. And so I don't know if you've come across this. This happened in the US recently, and this is article. This came out in the New York Times. So this basically because Medicare started giving outpatient billing procedures reimbursed. So people started getting out of hospitals and build their own outpatient services. So where they were doing this artery to prevent this artery opening procedures as outpatient procedures, and they were doing multiple procedures within a short period of time. In the end, causing amputations in several patients. So basically, because it is a Medicare driven, it is a state funded issue. There are incentives to increase the numbers at the cost of the poor healthcare delivery. So if this can happen in US, which is one of the most regulated medical for healthcare. So I just wonder what are things that can happen in India, where several such schemes are there, and there are numbers that are being always touted that these many patients are treated by this, these many are become they didn't have to go to a private hospital. All those things are good, but we don't know. We don't have enough data to say that actually they got good quality care in these from using these schemes. So basically, what is accountability for the outcomes in private healthcare? So if it's a consumer funded, if the patient themselves is paying, so they will take accountability from the doctor as well as the hospital. If they are not happy with it, they can complain, they can tell, they can even take the patient and the hospital to taking the doctor and the hospital to court. So they have some rights, and usually the accountability is much better in consumer funded uh, process. And what about charity funded? The incentives for the people who run the hospital is to show good numbers, and it's very easy to keep the funders happy with a good looking report. So what the funders are looking for is a good report that they can see and say that they have involved in philanthropic activities. So this also, the accountability is much lower than a consumer funded healthcare delivery. What about the state funded? It's the lowest accountability for outcomes, because the state funded, they don't even keep basic data for outcomes. Whether it's government or private, we don't know any outcome data, and it's difficult to compare what is what. So most of our comparisons are anecdotal, because that is what happens when we don't have data at the basic level data that is not collected. So and when it is state funded and it's private delivery, then both the hospital as well, hospital and the state both are not accountable, because because patient doesn't know whom to ask for if they have a optimal outcome. So we've heard of these eye surgery camps, the bot surgeries and all that, but what is the root cause of these things is basically people are there is a network that is formed for making these eye surgeries, and of course cataract surgeries have become more simpler and faster, and we are able to do more cataract surgeries at a shorter duration of time. All those things are true, but the problem is when it is over several thousands of patients are being operated on a daily basis, the quality comes down, because the pressure is to do the maximum number of surgeries in a day, so that they can whichever NGO or the private hospital wants to cash in on the maximum number of profit. So basically this model itself is the problem. It's not that the surgery or the surgeon or the hospital is the problem. The incentives that are at play is the problem. So like I said, mentioned earlier, I am also part of a non-profit. So we not just believe in funding these initiatives in remote areas. We also want to educate, do capacity building in remote areas where there is no available care available. So one of our first projects was in Sambalpur, which is a very tribal belt. It's in West Odisha. So there, the nearest eye hospital, nearest tertiary eye hospital, or even a secondary eye hospital is almost 200 to 300 kilometers. This is either Raipur or Bhubaneswar. So, and earlier the roads are not that great. Now the roads are much better, but even then it's quite a big distance. So we have one Dr. Shiva Prasad Sahu, who is a local there, who is an ophthalmologist who we partnered with in 2014. And now it has become after so many years of capacity building and his own drive as well, he has built a 100-bed hospital in Sambalpur, and and it's become a tertiary care hospital where he trains other ophthalmologists from across the world to do cataract surgery. So he does about 10 to 12,000 cataract surgeries a year. So we go there on a regular basis to do some academic programs as well as clinical skill transfers. And it's been successful so far. But so during COVID in 2021, during the second wave, the government of Odisha had built all these COVID care centers in all across Odisha. But as the first wave came to an end, so they then stopped. The whole thing was unstaffed. This whole hospital that they had built is completely empty. And then second wave hit, and there is no staffing. There are no people at all in Sambalpur to take care of all the poor patients who are suffering, and they're not able to even uh, come to the hospital. There's nobody to come to the hospital, and even though there is a medical college very close by, which is a government medical college, still they're not able to take care of there are no ICU beds, there are hardly any ICU beds, and still there are nobody take care of even the people who don't need ICU care. So then what we did was we were primarily doing eye care services, but then we had to raise funds to support this COVID care project. And the ophthalmologists in our partner hospitals doubled up to take care of these COVID patients. They were doing house-to-house visits to pick up the patients, and those who were little severe, we were shifting them to the COVID care center, and through other experts from around the world, we were able to assist them in managing these patients. So I'm wondering, this is just one little city in remote part of India. There were several hundreds and hundreds of other hospitals which are not so, which are other cities which are not so lucky, where there is no access to even a single doctor in and this COVID care center where we had this, which was run mainly with the ophthalmologists, and also other like Ayurveda, homeopathy, all the other specialists who were there, because they had to recruit anyone who was available, and all the optometrists also were doing duties on rosters. So, and this is how, once you get out of the city, this is how bad the access to quality care is. So, but even after all this, we still haven't learned our lessons. And even today, people are cheering the handing over of district hospitals to private players. It's not that private players are bad. It's important that they also get good exposure to hospitals and care in government hospitals. But if we are going to dismantle the government system to make up and replacing it with private, this is not going to improve our outcomes in the future as well. So in summary, it's not that all private is evil. There are some things, and there are well-meaning individuals within private and also who are trying to do good work, whatever is possible in their power. And we need more public, and also we need more private healthcare. So it's not that just that public healthcare it has to replace all the private healthcare. There is good happening in both spheres. And we need more public because we have such a big population, and we cannot afford to have public healthcare receding in favor of private healthcare. So we also need to improve training standards, and training standards not just includes improving the standards itself, also in resource restrained environments, how people would be able to manage and increase the total training positions across the board. So, and also, like I mentioned, the state-sponsored private healthcare is a stopgap solution. It will not solve deeper-rooted issues in healthcare in India. Okay, thank you very much.
Thank you, sir, for a very comprehensive presentation. And it was interesting to listen to the other side as well. Coming from a private background, that all private is not evil, and I totally agree with you. And I would request everybody in joining us in the audience today to, if they have anything they want to ask, you can feel free to unmute yourself, ask a question. But I would start off by asking Sunil, sir, like we just heard that all private is not evil, and CMC is a private institute. It's not a public institute. It provides standard care, probably gold standard care at a very minimal cost. And it still is a private institute. So if you could share a bit about the model of functioning of how, because you have been the director, how the finances are taken care of, and despite being a private hospital, how is it managing to give affordable, high quality care to poor people? So if you could just shed some light on that.
No, CMC is a very unique model. In that, it's actually 123-year-old product. So we often forget that it's a product that has been fine-tuned by hit and trial, trials and tribulations for more than a century, and we are just seeing that final product. So, it's been a struggle for CMC in the early years. It was totally funded by missionaries. It was much smaller, and it just grew on itself. But the essential philosophy of CMC is that no patient will be turned away. So, there is something called the economy of goodwill, which modern economists don't understand. They have banked on a faith-based goodwill generation. And it's not overnight. It's taken several decades and almost a century to establish that brand. We don't have a brand as such. But if you say CMC Vellore, people, especially from the eastern parts of India, know that it stands for quality care. There's a lot of, even if we don't have enough money, we can go there, we will be received. You see, so how a private organization still incorporates empathy and compassion is the basis on which an enormous amount of trust is built. Now, God forbid, I keep telling, people who ask about CMC Vellore that if the care goes bad for the next 10 years, people will still flock in. I'm hoping and praying that it won't, it will not. I'm just giving you a hypothetical situation where the brand is so strong, the trust is so strong that it'll take a decade to undo if, the care suddenly disappears from, its platform. So that is the essentiality of goodwill, that's why I said in my last slide that every private enterprise must decide to do 10 to 15% of their work charity. You know what it will do? It will actually increase their profit margin. So it should become a byproduct of good service. And that is essentially what CMC Vellore does. No patient is turned away because there's no money. We are taught from our school days, from our medical college days, that treat the patient first, then talk about everything else. So it is built on this foundation, it's a citadel of trust. And that's very strong. It's much stronger than money. Money will come. And you can see that even when post-COVID, there was 12%, 20% occupancy post-COVID, not during COVID, for all the corporate hospitals all over India. CMC had no place. People were just flocking in because they knew that, something will be done even if we don't have. So it's a pilgrimage experience for them. And I see no reason why all private setups can't go this way. Of course, there is a catch to it. There's an austerity principle that runs through the DNA of the institution, that the doctors take limited salaries. So there's an ethic of service that runs through the arteries and veins of the institution. That's also essential. So it's a happy mix of several things that have not evolved overnight, but over a century, more than a century and a quarter. And the product is quite robust and enormous amount of patients. With 13 to 15,000 outpatients a day. 60% of which are people who are from the distanced, downtrodden, disadvantaged group of people. And, the money just comes from the private care that is given. It is used to defray the expenses of. So that's how it works.
Thank you for sharing that, sir. There are a few comments in the chat box. Rema has said that 99% of the doctors will not be willing to work for salaries given by CMC. Any thoughts on that? Anybody joining us? There's also Swati, who's also from CMC, who's saying that seems also a place where seems also a place where passion and aptitude of healthcare professionals are valued. And I have personally experienced that. So I feel at the end of the day, when you get so much value for your passion, aptitude, you don't really think about the salary. Any other thoughts from people who are joining us? Rema, if you don't mind unmuting yourself, sharing your thoughts.
Can I respond to Rema's question?
Yeah, yes, sir.
Yeah, I know Rima personally, so I'll take the liberty. She's asked me this question before. So, it's not that the salary of doctors in CMC is today that awful or pathetic. It's not. CMC believes in an overall quality of life. So if you actually cost the value additions that are given, and I think this is very important for healthcare setups, housing, comfort of a campus, children's education, free medical care, good pension, because these are all uncosted value additions, which are also part of your cost to company or package. You have to be willing. So there is an automatic selection that happens, natural selection, that those who are not willing right at the beginning will say, well, this is not for me because my needs are different, and they'll quit the system. But those who stay have already accepted and it's been indoctrinated into their system voluntarily that, yeah, there are so many other things that, CMC is giving us. For example, medical care for life, even after you retire. Now, if you cost that in today's cost structure, it's a huge thing for your parents, for your spouse, for your children. It is a total value addition. So one has to value that to say that, yeah, it's a good thing to exchange for money. And what is uncosted also is job satisfaction, the freedom that you have for work, the job fulfillment that patients bring to you. All these things have to be given the necessary value. But I do agree that it is not something that will attract the younger generation who monetize everything, and they just look at their salary packet, take-home salary, which will not match the rest of the private sector. So it's a choice issue.
I think a lot of the questions have been around CMC, and there has been a huge misconception that CMC Ludhiana and CMC Vellore are run by the same people. So there's a question from Rema again that why hasn't CMC Ludhiana, why is it not like Vellore?
It is actually an older institution and has got the same philosophy, but it's not run by the same board. They're two separate organizations. It just happens to have the same acronym or same abbreviated name, but it's a completely different setup and in a different environment. But it's older, but the essential value systems are the same.
And again, another question is, how can this be replicated in other private institutes?
One IAS bureaucrat told me many years ago that, CMC is so unique that it is not possible to replicate that. And I think that is absolutely true. Again, it's a 100-year product, in a crucible of fire, it has been tempered and toned and refined. So it is not easy to replicate that. And until and unless you follow the same model for the same period of time. So that's a downside of, saying that it is so unique that it is difficult to do. But there are a lot of good things that the good takeaways that, and much of what we talked, all our panelists have talked about the same issue, which, as you know, part of that, it comes from the same. So it's not CMC alone today that practices these values. There are several organizations, just that we need to bring together these people who carry these values and bring it to the benefit of society.
There's another question if Swati, you would like to, Sonali, if you would like to answer that.
Yeah, I'd also like to answer. This is a research gap, right? If you look at the US, you'll find many articles on how Virginia Mason became Virginia Mason, how Geisinger became Geisinger, about Kaiser Permanente, about NHS and how its values. Where is the research work in India? Maybe it is there and I'm not aware of it, but definitely not to that extent. I would love for some organization development kind of stuff, researcher go into CMC Vellore and actually delineate what are the values, what makes CMC, we don't have that kind of work happening to a large extent. And even though the entire model may not be replicable, these are unique things that happen, like the Madurai eye care thing and others. But there are principles that could be applied elsewhere and learnings that could be taken elsewhere. But that agenda needs to be developed. And a lot of that is not that, not that prevalent right now.
Yeah, we have already crossed actually more than 1.5 hours, but Deepak, please go ahead if there's anything you want to ask.
Yeah, sorry, Parth. It's just on the dot. I've been hearing with interest. I missed the first 15 minutes. Sorry about that. But I work in the space of public health palliative care in Kerala. And I was just wondering, this is a comment plus a question, but we take it more as a comment. When I ask even my batchmates that, why is it that you want a certain specialty? They have no clue most of the time. At least 90% of them have no clue why is it that they are taking a specialty. And many of the MBBS students who are undergrads whom I have gone through, they have no idea why they have even taken MBBS in the first place. And when I work in my primary work has always been in the rural areas in Karnataka, Tamil Nadu, and now in Kerala. And I see that there is not even a single doctor, even in like 60 kilometers away from a city center. So it's not like it is some rural area which is 200, 300 kilometers away. It's not even that far. Even in the penumbra of the cities, we don't have even a single private doctor. There are situations like this where I worked at. And I'm thinking privatization is definitely something which is needed in the sense, during I don't remember the reference right now, anywhere between 60 to 80% of healthcare which is accessed is private. And on the other side, I also hear statistics like anywhere 70 to 90% or 70 to 80% to be safe of patients who end up in a tertiary care center, their issues could have been sorted in a primary or a secondary level care. And when this is what is happening, and I see like enormous potential for de-burdening the health system in the tertiary level. And I see patients who are not able, they can't afford even to travel from that rural area to reach a private facility or even a government tertiary care facility for that matter. And I just think that doctors really have no clue that how is it that they can stand on their own feet and what is it that they want to do. Like Dr. Hegde was telling that doctors' field is saturated in many ways. This is in the urban areas. Like I see so many doctors who are scrambling for higher degrees for want of a safer job position in a super saturated urban city in a good hospital. And they have no clue that if they move a little further away, I'm not even talking to go into a zone of discomfort, even 50 to 100 kilometers away from an urban area, there is so much potential to have a healthcare setup which is private. At the same time, they can have really good income. And I know this from some of my own batchmates in Tamil Nadu. They have, it's their parents who started off the business as a small nursing home. And now they have a facility in which they earn in crores in a year. And this is a gap which doctors are not aware of, probably because it is not talked about or taught in the undergraduate curriculum. Forget postgraduate curriculum. Probably me being in community medicine space, I'm able to see that. But otherwise, people who are into specialists, specializations and super specializations, they're just stuck in that four walls within a hospital without having any clue about where is the scope of things where they can contribute if they are just ready to move a little bit out of their comfort zones, which may not give them the white collarness of saying that I work in a big shot, hospital where I have a AC waiting room. They may not have the luxury to say that, but they don't have the eyes to see, and our system doesn't have the mechanisms to show them that what is the satisfaction or the gratification which they can get if they just step out of this comfort zone, try to stand on their own feet and do a social entrepreneurship, I would use that term very consciously, social entrepreneurship, to make sure that people who are really in need are reached out to. And this CMC model of care, I'm sure I'm thinking very far ahead, but if thought about in a very good way or in a planned way, decentralization of care can happen in a very private manner also. And this decentralization of care, for example, like for farmers, to have more say. There is a farmer produce organization. Just like that, there needs to be some body apart from IMA and things like that, which is very routine, where doctors can be guided to have these kind of health-based social entrepreneurship models in the rural communities or in the peripheries. I think that's the shortest I can put my lot of thoughts going on in my head in.
No, thanks for that, Deepak. And you rightly said, a lot of the people don't know what the opportunities are in the social entrepreneurship sector in India. And I personally feel medical education has a huge role to play. And I'll just cite example from CMC that we have postings in rural areas every year as a medical student, which is called Secondary Hospital Program, SHPs. And we would get posted for 2 weeks every year as a medical student in rural parts of the country, remote rural parts of the country. So we knew where the need was, and again, that thought was there in the back of our mind that ultimately we could possibly end up serving there. I would take one last question if anybody has in the audience. I think Dr. Raghuraj has answered some questions in the chat box. If anybody has any further comments from the audience, any last questions, I think we can
Yeah, hi, I'm Shakib. I work with Catholic Health Association of India. So I work basically with the Catholic organization, and I closely work with CMC Vellore, CMC Ludhiana, and Leprosy Mission Hospital. I would take a little balanced approach, considering that I come from a development and background NGO sector. Few of the things where I feel there has been a lot of success with public-private partnership is eye care programs, especially if you see from National Program for Control of Blindness, where the majority of the work has been done by the private or NGO hospitals, and they did very good work. However, it still runs at a risk in the future, considering the tight FCRA regulations, and we believe that will further lead to squeezing of the space, and this may impact this success story. Second thing where I feel where the private entity has played an important role is building the human resource development. If you see, majority of the DNB seats are in private sector, not in government sector. MDMS are in the government hospitals, but when it comes to building the postgraduate students, they are coming from the private sector. So this is where I feel they have played a very important role.
Yeah. Thank you for sharing that, Shakib. If you want to go ahead, please mute yourself, Mr. Arjun.
I have 2 quick points to make. See, one of the 2 distortions are health insurance is the big source of revenue for the large corporates. And almost 80,000 crores is the revenue that goes from insurance sector to the healthcare sector. And that is it's not evenly spread, and it's more tilted to the metros, to the large hospitals, towards more advanced diseases. So this distorts the behavior of patients as well as doctors and hospitals. So that is one thing. So if we can work together to correct the quality of the revenue flow, okay, so we need to work with the health insurance industry in how it implements it around the year. The second big distortion is medical tourism. Okay, so while it's a good thing that India is doing for the world, effectively in many places it jacks up the prices for the local citizens. Okay, because the big hospitals give first preference to dollar revenues from the medical tourists. So these are 2 things that I wanted to bring.
Thank you for sharing that. I would like just ask my speakers to, if any closing thoughts, if you would like to end. Yes, Dr. Raghuraj.
Rima had raised that most of basically the corporate sector only caters to 5 to 10% of the population. I agree. And most of the private healthcare that is there is actually the smaller nursing homes, small clinics, the smaller clinics, and sometimes they're not even qualified physicians. So they're just alternative medicines or just quacks in most cases. So that is also considered private healthcare. So, but the thing is that there's a trust deficit even in the public healthcare system. So even if a public healthcare is available, the patient still goes to a quack to get his thing sorted, because the access to healthcare is poor, even in public hospitals. The way to reach the hospital, the cost of reaching the hospital, as well as stay in hospital, all of that is very expensive. So I think the trust on public healthcare is also a problem. It's not just that there are not enough public healthcare. There are not enough, at least not enough for a country like India. But the trust in the system also is missing. So that's what I wanted to say. Even though, like I said, even if a public hospital is free of cost, they still would prefer to pay and go to a private doctor or a quack to get themselves treated. So that says something about the trust that is missing.
I totally agree with you. The place where I sit in for my community medicine clinic where we practice, just 100 meters away from there sits an informal practitioner. And patients don't come to me. So I had to go out and sit in the community and ask them, why are you not coming to me? Why are you going there? And they said that guy has been here for 15 years. He's open from 6 in the morning till 10 in the night. You guys leave at 1 o'clock. He has treatment for everything. You tell us to buy medicine from outside. So even if he's not giving the right treatment, he's he understands their background well. He's been there. He's like a family member to those people. So again, that trust really makes a lot of difference. So thank you for sharing that. Sonali, any concluding words from your end?
I just want to thank everybody for coming, and I think this is a political agenda, and we are all political actors.
Yeah.
And at the end of the day, the choices we make matter. So that's it. Thank you so much for everyone for spending your time. And thank you, Parth, for organizing and bringing all of us together. Thank you.
Thank you, Sonali. Professor Devi, anything from your side?
Absolutely echo my co-panelists here. Thank you so much for this forum. First of all, I think it's so rare that we end up talking about public health concerns. So this forum itself is, I think, valuable, and thank you for the work that you're doing. I do see the need for how do we imagine alternatives. CMC is a great example of that. I agree that it may not be replicable as is, but I wonder what can we learn? And in itself, it presents the fact that I was just telling Kiran on the chat that it presents the idea that alternatives are possible in this world. It's not in the future. It's already there. So what do we learn from that? And we have similar challenges with palliative care as well in Kerala. Why did it not translate beyond the state? Everybody asks that. It's there in Kerala. Why does it not go beyond? But I think the question is then what elements can you take from it? So these are, I think, ongoing questions for us. But like Sonali says, I think these are political agendas that can't be resolved in should be ongoing conversations. So thank you so much for the opportunity to be here.
Thank you, Devi. Sunil, sir.
Again, I just want to echo what Sonali and Devi have said. We've just skimmed the surface of a hot topic, which we can keep talking for the next 30 days and still not reach anywhere. But it's a good start, it all starts from a brainstorming session like this. And even if it's a small group, if you have a commonality of thinking and the motivation to make a change, it's possible to make a change. My sense is that today there's a lot more public healthcare consciousness unsaid, unrevealed in the minds of people who, I engage with. They do understand that something is not working, therefore we have to go back to the basics. So from the crowd that we have gathered here today, you can see the resilience in thought and word in the comment column. So I think you should consolidate this, maybe write it up and see how you can take this, onward and upward. It is worth it because we are heading that way. There's no choice for our country but to adopt more robust public health interventions, and that's going to happen. It has to happen. So thank you everyone for being on this forum, and especially Sonali, Devi, Dr. Raghuraj. It's a pleasure meeting you, and we'll keep in touch. Thank you.
Thank you so much. Thank you.
Raghuraj, sir, any final words from your side? And then I think we can close for the day.
Yeah, basically, I think all the major points are listed. And also, another thing I wanted to touch upon was that regarding this insurance. So insurance-based healthcare. It's all well to say that we will provide healthcare insurance to all the people and there will be universal health coverage. So this is essentially what all the state schemes are doing, as well as the Ayushman Bharat also is doing. But it is not sustainable because in the end, you're paying insurance companies with taxpayer money. And insurance companies will stop paying once the bill goes above their higher levels. And at some point, the payments stop coming and the hospital stops service. So, and then the whole system that you've developed over the years, it all comes to a standstill and we have to start from scratch. So this is what happened in many of the state schemes like Yashaswini, RSBY, all the schemes. And again, we keep getting the same iterations of the same scheme in different avatars. So I don't think that is going to solve the long-term problems. So I think insurance-based programs are not going to help long-term problem. It's good. It's good to have for the private hospital and the people. It's good to have a health insurance. But how many people can afford insurance premium on their own? So how many people in the country can afford? Hardly, I think about 20% penetration is there, even in urban areas. Forget about rural areas. Even in urban areas, it's hardly 20% penetration. So how many people can afford an annual health package for your whole family? I don't think it's a sustainable model. The more sustainable model is to improve the healthcare, public healthcare sector. Infrastructure is important more than paying for private healthcare delivery through these insurance companies and these schemes. So I think that's my point.
Thank you. We had planned for a 1 hour session, but now we are closing on almost 2 hours. So thanks a lot for your time, for joining, and for contributing to this platform. I hope that we can continue to talk about these issues. Hopefully, bring enough attention so that enough people talk about it and it becomes a part of our daily conversations. Thank you once again for joining us today. There's a link I have posted in the chat box for feedback. Kindly fill that form, help us improve. Our next forum is going to be end of this month on disaster management in India. And we have, again, an amazing lineup of speakers who will be sharing their work from on-field, from tertiary care hospitals, and from their experiences abroad. Sonali is going to co-host that with me. It's in collaboration with Include Labs. We'll share the details soon, so please stay in touch. You can also sign up to our newsletter. It's a monthly newsletter, so we won't be spamming your inbox. We'll share more details in that newsletter as well. So thank you once again for joining for 2 hours today. And I hope you have a good week ahead. Take care. Bye.
Thank you.
Bye for now.
Bye. Thank you.